Backache is very simple problem, but if not taken care, it can become a nuisance. And as per the statistics, 80% of the people at one point of time, either they have suffered or they'll suffer from the backache. So your family, friends, in your group, any given time, somebody must be suffering from the backache. So this is only to give you a brief idea about what is backache or back pain and what are the primary or the basic investigation and the treatment modalities. This is the same thing why we should know about backache. Low back pain is very common. 80% of the population suffer at least once during the lifetime. Usually our spine has a S-shaped curvature, and as per on an average, we bend forward around 3,500 times in a day, starting from we get up from the bed to brushing the teeth to taking the bath to anything. So S-shaped curve, we are making it abnormally C-shaped curve, and that is where the problem lies. And backache is, as I said, very simple, but it affects the quality of life. What is the definition of backache? Any pain or discomfort between the lower costal margin and upper buttock margin. That pain is, we can define it. It may be associated with radicular, that is leg pain, or without leg pain. So you can see the low back pain below the costal margin and above the gluteal region. What is the etiology of the same thing what I said? The S-shaped spine becomes C-shaped, almost 3,500 on an average, 3,500 times. And if you think about it, the moment you come out of the bed to the first thing, brushing the teeth, everywhere we bend forward. Etiology is non-spinal causes of low back pain and the spine-related issues of the back pain. Causes of low back pain from a simple strain or muscle spasm to fracture spine, traumatic, osteoporotic, old age, postmenopausal, infection like tuberculosis or discitis, that is the same infection, tuberculosis, arthritis, the facet joint arthropathy and all that. And related to the, which are of more importance, is the spinal tumors, spinal instability, that is spondylolisthesis, structural problem, lumbar canal stenosis, lateral recess stenosis, osteophyte degenerative, disc injury, traumatic, or because of our the habits, and disc prolapse. There are two types: acute, like suddenly we bend forward, try to lift 10 kg or 20 kg of the weight, and we are not used to it, and we get sudden spasm and we cannot make ourselves straight. That is the acute injury. And chronic is like because of so many etiology which I have said before. What is the character of the spinal pain? It is either the sharp or dull pain, or may radiate to buttock, or may radiate down up to the toes. Tingling or numbness, worst on bending forward and relieved on lying down or on mild extension. Now the most important thing, or many times the patient, they come and say, I had only backache since 6 months, and now the backache has gone, and I am getting tingling, numbness, or the pain, radicular pain in the lower limb. So that is the worst scenario. They feel happy that the pain has gone, backache has gone, so they are relieved. But it's other way around, it's not a good sign. And other way, the pain starting from the radicular pain and then centralizes to the back, and the leg pain goes. That means the irritation over the nerve has gone. So centralization of pain is very important for prognostic and patient point of view. Symptoms are stiffness, postural problem, muscle spasm makes it difficult walking, standing, from sitting, getting up. Now, the most important things, the diagnostic tools and the management. So in the diagnostic tool, we have starting from plain X-ray to CT scan, 3D reconstruction, MRI, and when this MRI was not available, we are from the era where we have seen the myelograms and the MRI and the recent MRI. Discogram, when there are two levels disc problem, then we are not sure. Or on MRI, you don't find a huge disc or a major disc herniation, still the patient's symptoms are very severe. So it's difficult to diagnose whether the disc is the culprit or there is some other problem. Or multi-level disc, we don't know which level is culprit. So in that thing, discogram is important, bone scan for metastasis and all that. This primary treatment is the facet block, SI block, starting with the basic investigation like blood investigation, raised DSR and all that for investigation of multiple myeloma. When there is a non-compressive pain or radicular pain or neuropathy, then EMG nerve conduction study, CT scan, 3D reconstruction. These are the X-rays, plain X-ray showing the trauma, fracture or osteoporotic wedging. Here you can see there is minimal wedging of L1. MRI is a gold standard in any spinal problem. But at the same time, a word of caution that it overdiagnoses the thing. If you normal population without any back issue, if you take the MRI of that person above 65 of age, then in 60 to 55 to 60% will find the positive MRI showing something on the MRI. So the most important part in MRI is we have to correlate clinically and radiologically. This is old system, myelogram. When MRI was not available, we used to do the myelogram. Discogram showing the dye in the disc space, and as I said earlier, the multi-level disc problem, or to decide whether the pain is of discogenic or non-discogenic origin. Lumbar canal stenosis, you can see there is a severe cutoff, myelographic cutoff on MRI. Spondylolisthesis, you can see the forward displacement. This is a huge herniated disc, large on the axial MRI scan, large disc. So these are the basic investigations, or the stepwise we have to go from starting from simple investigation from blood, X-ray to MRI. Now now we come to the disc problem where we are more interested. Disc prolapse are of 4 grade. There is a disc bulge, disc protrusion, disc extrusion, and disc sequestration. Very grossly saying that, I mean, it's not a rule of thumb, but 1 and 2, that is disc bulge and disc protrusion, by and large can be treated conservatively. And disc extrusion and sequestration, by and large, they require surgery. Here you can see the alpha S1, there is a large disc herniation. Now the most important part is the management. Management is in 2 parts, the medical or a conservative management and the surgical management. 90% of the patients suffering from disc prolapse, as I said, disc bulge, prolapse and early extruded disc, if given proper treatment and proper rest, 90% they get cured with the medical management. So medical management is like rest and ice or hot application to the back, NSAIDs, muscle relaxation, those who are not responding to this treatment, and those who have severe pain, then we give epidural injection or the transforaminal injection. Now, the most important part, the indications for the surgery. according to me, there are only absolute four indications of the surgery. First is neurological deficit or a cauda equina syndrome or a sphincter involvement. That is the dire emergency. There is no role of conservative trial and one has to rush and do the surgery. Then the claudication, where person cannot walk or cannot stand for a long time. Then the claudication, professional restriction like the executive, they have a different indications, and the labor class people, they have a different indications. So depending on that and types of surgery, starting long back when we started our journey as a neurosurgeon, we were taught that wide laminectomy and discectomy is the answer. From that, we have come down to the fenestration technique, very small fenestration, take out the disc, hemilaminectomy, microdiscectomy, the gold standard till today, laminectomy for lumbar canal stenosis, and endoscopic MIS, minimally invasive spine surgery, that is transforaminal and interlaminar. This is listhesis, fixation. Prevention is always better than cure. So structural problem, maintain the healthy height, healthy weight, strengthen the abdominal muscles and lifting the weight in a right way. These are the future trends in the spine surgery. Take care of your back and back will keep you moving. Thank you.